Good morning, and I want to thank the opportunity offered by the symposium committee to share our experience on the clinical application of the OGM in cancer cytogenomic diagnosis. Today is more focused on the characterizing the atypical and complex KMT2A fusions in ML. And as many of you know that 11q23 translocation involved KMT2A is a recurrent abnormality in de novo and therapy-related ML. And we know that there are more than 100 patented genes with six major translocations in ML, like 411 is primarily in the BAL and others in myeloid ML. And these are all the diagnostic based on the WHO classification and the ICC classification. And second, this translocation is also associated with a adverse prognosis in AML and ALL, except for those patients with 9/11 might have intermediate prognostic impact. Lastly, the detection of the KMT2A translocation is significant because there's a new clinical trial, as you can see, that just published in Nature earlier last year, that it was led by Dr. Stein, who is our leukemia service chief at MSKCC, that patients with 11q23 translocation or KMTA partial tandem duplication are eligible for a very efficient clinical trial using a menin inhibitors. And that's why for us that we have been running clinical trial, running cytogenetic fish analysis in all the patients, and many of you that those recurrent abnormality or those six major ones should be detected by a karyotype in majority case. Obviously, some cases will need fish confirmation, and specifically we know that few cases will have very exceptional situation with either critical translocation or very complex translocation in ML with involving KMT2A. So today I want to share with you with the three cases we actually went through, and we learned a lot and understanding the important clinical implications, application of the OGM in these patients. First case is a 74 years old female with a newly diagnosed ML. And as usual, we do our test menu as a karyotype start and around with the fish analysis for KMT2A and p53. The reason we run a KMT2A fish at the beginning because we want to support Dr. Stein's clinical trial for screening for the ML with 11q23 translocation. On the left side, you can see a normal karyotype with a female XX, and both chromosome 11s are normal. And the fish analysis on the right side also showing two fusion intact KMT2A signals on the both chromosome 11s. So we reported this as a normal karyotype, negative KMT2A translocation, and no evidence for TP53 deletion. However, a week later, we learned from our Archer fusion study in the other lab at MSK that this patient was positive for a fusion with KMT2A and MLT10 fusion, which is supported by a very high quality of the reads and also studying reads. So we were a little bit frustrated for this kind of missing analysis. So we did a fish analysis using MLT10 split part probe, and you can see that fish confirmed MLT10 abnormality in more than 40% of cells with 3 primers in very signal on the abnormal chromosome 11. And obviously, this case, we did the OGM study, and you can see on this is a circle plot. It's very clear that OGM confirms there's a fusion between chromosome 10 and 11, along with a small deletion near the split point on chromosome 10. And we zoom into the chromosome 10, you can see there is a fragmented deletion in this patient that is about 900 kb deletion, including 3 primers portion of the MLT10. And OGM was showing a connection between the KMT2A biprimers and is also 3' MLT10 fusion. And there's also we noticed that another fusion between the 3' KMT2A and the fragment on chromosome 10p. However, there's no really gene near around. So we can clearly see the fusions 3' KMT2A and there's another fragment from 10, chromosome 10, but no gene defined. So we understand interpreted this case is an insertion of about 919 kb segment from the 3' portion of MT2A into the KMT2A2A. And this is exactly we observed, detected by OGM that you have one end of the fusion 5' KMT2A with 3' LT10, and on the other side, there's another fusion involves 3' KMT2A, but no defined unique genes at this end. So this is something we learned that is quite insertion of the 3' MLT10 into the KMT2A. The second case I want to show that a 7-year-old boy with a relapsed ML transferred from outside. Unfortunately, the patient was at 14 months relapse post-induction chemotherapy. And the patient was known that at the beginning of diagnosis that the patient had a 9/11 translocation involving KMT2A MLT3 fusion. So when patient comes into the MSK and we did a chromosome analysis, on the left you can see this is definitely patient has karyotype with +8. And there's also unbalanced translocation involved the short arm terminal 1 with a piece from chromosome 14. But both pairs of chromosome 9 and chromosome 11, they were really normal. So we look at it here, but at the same time, actual analysis at MSK also confirms this fusion is true. So for us, that it's a little bit trying to figure out what is the situation for this case, right? And obviously, we did a fission analysis with KMT2A break particle. And you can see on the left, we use a probe from Abbott molecule, and 5' is near the centromere labeled in the green, and the 3' is labeled in the red is telomeric. In a typical translocation 9/11, you will see abnormal cells of one normal fusion and a radical separation. And on the metaphase cells with 9/11, you will see that the 5' emerging remain on chromosome 11, and then the 3' red signal should move to the partner gene on chromosome 9. When we look at our case, that you can see it's a very unusual fish signal patterns, as shown on the top that two interface you see one fusion, and then one red, one green, and there's also second green signals. This is something quite surprising because we did not see +11 situation, right? Then we look into the metaphase. Here you can see that on the left, you can clearly see normal 11 with the fusion, and the red signal 3' that remain on chromosome 11. Two green signal 5' actually move to the terminal on the short arm, both chromosome 9. So this is a very, very unusual, looks more like a very complex genomic aberrations or something else. So we applied also the microarray to look at this case because this trying to understand. You can see that here, obviously, the +8, and there also is a copy loss on the short arm, terminal short arm chromosome 1, and gain of chromosome 14q. This is consistent with unbalanced translocation between chromosome 1 and 14. And there's a small piece of the gain of the 11q involved portion of the KMT2A. Interesting that we also noted that there's a copy neutron LH of the entire short arm chromosome 9p. So that's all we know from the conventional chromosome fish and microarray. The question for us is very unusual that what is the mechanism that are not involved in this critical 9/11 translocation, because both 9/11 are normal, and then also the fish signal pattern is very unusual as well. So the OGM actually on this case is confirmed there is here's on circle plot. You can see on the right that there is two translocations, obvious chromosome 1 with chromosome 14, along with the deletion of this terminal 1p and then gain of 14q, which is consistent with what we describe on the karyotype that unbalanced translocation 114 and confirmed by microarray. And the second fusion is obviously it does have a chromosome 9 and chromosome 11 fuse, along with a copy neutron LH of the entire short arm chromosome 9. And then in addition, of course, +8 was also revealed. So these are all consistent with what we observed, right? However, OGM is really helpful us to understand what is the mechanism for this case. So on chromosome 11, you can see there's this is our patient DNA images. In this case, you can see we are missing of the 5' region of KMT2A around with its upstream flanking region here. So this piece always is missing, but it is not really deleted. It's more like relocated to somewhere. So when we look at chromosome 9, and you can see actually those missing pieces from chromosome 11 was 5' KMT2A, and upstream region actually is located in the middle of the MLT3. So this is definitely is a insertion mechanism, right? So here you can clearly see MLT3, and in the middle, those two fragments actually of chromosome 11. And if we look through here, clearly see that there's a 5' KMT2A connected with 3' MLT3. Obviously, because two genes have a orientation opposition position, so that's why they have to be inverted of one of them. In this case, as MLT3 got inverted, that's why you see the right 3' to 5' to 3' connection of the KMT2A with MLT3. And so obviously, very interesting based on the microarray, copy neutron AH9P and OGM, we assumed and we interpreted that in the 9P that you do have a small piece of insertion from the ML into the MLT3 on chromosome 9P, and the 9P should got a complete duplicate. Is likely the mechanism like in constitution was the trisomy rescue or whatever, and but obviously because the patient came here as a relapse, so we didn't have any opportunity to look at the diagnosed sample, see whether this is copy neutral AH of 9P is a secondary abnormality. The third patient is more interesting. I want to share with you. It's a 77 years old female patient with a mixed lineage phenotype involve the myeloid phenotype, T and B cell phenotype. And the patient also had a 9/11 translocation. But you can see the breakpoint at chromosome 6q is not typical. It's not at 6q to 7 at the terminal, more like in the middle. And outside fish was negative. Before patient actually came in, I received an email from Dr. Stein. As mentioned, he is in charge of the clinical trial with the main inhibition at MSK and nationwide. And it was confusing that this patient has 6/11 translocation, but fish was negative. So what is the main question from him is that can he put this patient on clinical trial at MSC and allow the outside physician to transfer that patient to him? So when patient came in 3 weeks later, and we did chromosome analysis, you can clearly see that on the left, patient did have a balanced translocation between chromosome 6 and 11. And for most of you who are familiar with the cancer cytogenetics, this is definitely not typical 6/11 translocation in ML, right? Breakpoint in 11q looks like yes, but breakpoint in 6q is definitely not. And on the right side, you can see the clonal evolution. Besides 6/11 translocation, there is also 4/14 translocation and 5q deletion as a major clone in 15 of 20 metaphase. Remain 4 is here. So this is looks like from this karyotype analysis, clonal evolution, 6/11 is a primary clone, and remaining with 4/14 5q deletion is a secondary. But obviously the question, and we did fish analysis here again, we confirm there's no ML fish split or deletion stuff on interface, and even on the metaphase, you can see normal chromosome 11 has fusion, and that abnormal 11 with a big piece attached to end from chromosome 6q. So also normal and remain on chromosome 11. That means the breakpoint anything on chromosome 11 is a distant breakpoint to the KMT2A locus, right? So the question here is what's going on in 6/11? Is this different mechanism as I showed you in the two previous case, or is if anything that any know what's paternity on chromosome 6q21? So OGM in this case really help us again. It's really on the right side, you can clearly see there's 2 connections. So you have 4/14 translocation and also 6/11 translocation, and around with a deletion of 5q. So remember, the OGM is powerful, can provide very accurate assessment of copy size in all these 3 abnormalities. The value is near 0.43 with 0.42. So it's definitely a major clones, and I think the tumor content is almost about 90% around. Then we look into those fusions on chromosome 4 and 14. You can see that there's two gene involvement. There's the DCK genes and there's the FOXN3 gene. I looked closely about their functions. DCK is seems to report in some hairy cell leukemia or neurofibrosarcoma, but the other part of gene FOXN3 is really not involved at all in cancer. Importantly, if we look closely, look at their genes connection, actually, this was a 5' to 5' head-to-head connection. Then theoretically, there's no function at all fusion, right? Because 5 to 5, there's no way you can make any fusion transcript, right? When we look at 9/11, which is a major concern about the patient's eligibility for the clinical trial, we did not see any genes at the breakpoint, genes involved directly. So this is something that's very interesting. 6/11 is a major primary clone, but did not involve any gene in both chromosome 6 or chromosome 11. However, we paid close attention to what's going on, anything about the KMT2A. So we actually looked at it closely. We did find in this case that there is a very small inversion near the KMT2A area, about 3 kb. You can see that is actually involved KMT2A and SCN4B, which is a gene is really not reported again in any cancer. And we did identify both 5' KMT2A and 3' SCN4B, and also the 5' reciprocal fusion, 5' SCN4B with the 3' KMT2A fusion. However, the clone size of this fusion is very, very small, 0.06, compared with those 3 major abnormalities near 0.4 to 0.43, right? So this case is quite informative, reviewed by OGM, that in this case, KMT2A is really not a major primary event in this patient. So to the summary of the case I presented to you of those 3, in the first case, we identified OGM that is an insertion of the 3' MLT10 into the KMT2A, which results in a KMT2A MLT10 fusion. In the second case, that is other way around, that the insertion of the 5' KMT2A into this MLT3 genes and results in KMT2A MLT3 fusion, in addition with a copy neutral energy features of entirely short arm on chromosome 9p. And the third case I mentioned is more interesting, that OGM confirmed all 3 major abnormalities, including 5q deletion, which is confirmed by FISH actually in 92%. And those 2 translocations really did not result in any meaningful fusion, like 414 did have a fusion with the 2 gene, but it's head-to-head, not functional. And the 6/11 translocation is no fusion at all. It's not involved KMT2A. And these, again, as I mentioned, that those a high percentage of the clone size matched to the FISH conformation is a primary clone. The finding by OGM on the KMT2A with SCN4B fusion is an extremely low level clone size, and because of the small inversion on that area, about 300 kb. We assume that this is most like a secondary event, and the significance is which is really not known. With all these results, and I discussed with Dr. Stein, and we made a decision that this patient is not eligible for his clinical trial on the menin inhibitions at MSK for patient with ML for the KMT2A regimen. So what I present to you from these 3 cases, and also based on our validation, I think it's very clear that there's a huge potential clinical application potential for the OGM in the leukemia diagnostic. Because here, as I mentioned, this is OGM can provide, help clarify and characterize the atypical fusions and those complex genomic abnormalities in leukemia. And remember, in many leukemia patients, they have always complex karyotype with a lot of unbalanced translocation and addition of unknown original material and marker chromosome, ring chromosome. In these kind of cases, OGM would definitely reveal the much better details of the genetic abnormality understanding. And obviously, OGM has the potential to identify the novel genetic biomarkers or the candidate gene that could be diagnostic related or even treatment related and prognostic impact. Moving forward from what we learned and from others presented in the last couple of years, symposium and also publication, we think the further study needed and more confidence is need to be built up to make sure that this OGM may be applied as a first-line test to detect all those clinically relevant structural and numerical chromosome abnormality in leukemia. The one where obviously at this modern time, all the leukemia patients need to be treated as quick as possible. So the turnaround time, so reporting all those findings by OGM is the key. And I hope that the new equipment and the new bioinformatics pipeline will allow us to get the results faster. And the second is obviously that higher sensitivity of AGM to detect those low level clone and subclone, and also those patients with coexisting disease, like ALL with MDS, CLL with MDS, how OGM can detect those kind of subclone, small clone is key. And finally, I believe that once we move forward to apply OGM in clinical diagnostic, I think the reporting system is still a lot of discussion needed as how to report that. In my view, I think we should report in the different tier steps for those well-defined recurrent abnormality, like those cases I present with 9/11, 10/11 translocation. We should report immediately to support diagnosis and prognostic risk assessment and even treatment selection. And all additional novel findings, or those not confirmed, not well documented in the publication, maybe needed to be further confirmation and can report separately. So to the end, I want to thank my laboratory at the MSK, especially for the Robert. Similar, he is the supervisor for the array group, and he's also the driving force for the OGM in the lab. He established this technique and learned all these analysis stuff. So it's a huge amount effort from contribution from him. And Angela is our manager of the lab, and she's really motivated and helped to get all the funding and space and also the staff to make the OGM available. Obviously, without all the support from the Bionano experts, especially Mike and many others, we probably won't be able to really understand so fast. All these analysis really based run on their input and telling us all the tricky and using the bioinformatics. So at this moment, I will stop it and happy to take any of your questions. Thank you.